Good. Let's pick up now with this condition, Syringomyelia, and I wish to goodness I had the image that Mike just showed me of a patient that they had in practice. So let's talk about this and then we'll mention that. Oh, and just briefly, someone had mentioned the case they just saw in their practice where a gentleman in his mid to late 60s working on a roof within a couple of weeks developed back pain, came in and had a very ataxic gait and shipped him over to the neurologist and then hasn't been able to follow up yet. But that was his presenting problem, was this ataxia. Now, Syringomyelia. It can be associated, and in fact the case that Michael showed is associated with Arnold-Chiari malformation, where you get a lot of increase in cerebrospinal fluid pressure associated with that disorder, which I don't know if it's just congenital, if it's genetic, what the case may be. It can, interestingly, be associated with trauma. That after trauma, you'll see the development of a syrinx. A syrinx being this enlargement of the central canal down the middle of the spinal cord. It can cause pain, which often has a distribution locally in the neck and then out across the shoulders. It's this, what they've been referred to as a dissociated sensory loss, where you lose pain and temperature but not proprioception. Anybody want to venture a guess why? As the syrinx becomes bigger. As a guesstimate? What?
Expands laterally?
Well, it is expanding, but why would it selectively cause a loss of pain and temperature but not of proprioception?
Spinal thalamic.
Well, it has to do where the fibers cross. So these fibers are decussating at the level of the cord. These are going up further before they decussate. So if they're decussating at that same level where the syrinx is, then it'll nail them. And very often, the distribution of this loss is, they call it the shawl distribution. It's where a shawl would lay over your shoulders and neck. And depending on where the syrinx is and how big it's expanding will depend whether you're going to get any motor deficit or not. And you would expect below the level of the syrinx, because of cord compression and corticospinal tract compression, you might start to see upper motor neuron changes below that level. But at that level where the syrinx is, if it's pushing out laterally, you might expect to start seeing lower motor neuron changes. And again, another late finding if you start to see sexual or bladder dysfunction. Here's a demonstration. Here's T2 weighted image. There's your fluid nice and white. Here's your cord filling the space. And then this large fluid-filled sac right down the middle part of the cord. That's a large syrinx. And the one that Michael just showed expands about 3 or 4 segments and literally fills the entire cord in a 30-something-year-old female. Another example of a syrinx, in this case, extending all the way up from, let's see if that one showed any Arnold-Chiari, which it can't really tell. The syrinx going from the upper cervical all the way down to mid to lower cervical. So it's really extensive. I'd love to see a picture of that. If you could email me that image, I could include it. It's a much better demonstration of a syrinx.
I'll send it.
Thanks. I'll make sure it's de-identified. So that's enough on question number 1. Again, the big, other than ruling out all those red flags, be very sensitive to cervical spondylotic myelopathy in your differential. Now, question number 2 in the algorithm, where's the pain coming from? And if you remember, we're going to look for 4 general categories of pain. Disc-related pain, what has been referred to often as a derangement. Joint dysfunction, which is facet joints, apophyseal joints, and maybe even joints of Luschka in the cervical spine. Radiculopathy, the nerve roots coming out in the cervical spine, and then this broad category of myofascial pain. So we want to try to classify as best we can our patients into one of these four broad categories of pain generators. So let's talk a little bit about derangement. And with derangement, it's felt to be disc-related, although if you read Mackenzie's work, he does suggest that you can even see derangement patterns at C1, occiput C1, C1, C2, which is no disc. So it's more about the pattern than the explanation of what pathoanatomically is going on. And quite honestly, from my own personal perspective, I think all of that speculation about mechanically what you're doing, am I moving the nucleus material over here, I think is a wasted exercise. And I think often really confounds the efforts to advance a particular approach. I think the more time we waste trying to understand exactly what's happening when you do a manipulation, or exactly what's happening when you do Mackenzie's protocol for derangement, I think we hinder our ability to utilize those tools because people get so hung up and start arguing about the mechanics of what's really going on, when in fact we're just guessing. We're just really guessing. So it's more important to just be really good, utilize really good observation. So we know with the discs that you get these tears along the annulus fibrosus that go circumferentially initially, and then if they're bad enough can even go radially in this direction against where the fibers are running. We also know from the recurrent meningeal nerve that the posterolateral third of the disc does have innervation, which carries nociceptive fibers. We also know from shearing studies and torsion force and shearing force studies that the part of the disc that is most susceptible to getting these annular tears and radial tears is the posterolateral third of the disc. Whether that's embryologically caused, whether it's because of where vascularization went in, I don't know. Or it's just the mechanics, the biomechanics of inducing a shearing force or a torsional force. That's where we commonly see the injury. This is a distribution of where pain pattern is, and again, I'm sure these were poor medical students, where they would just do an injection, or discography patients do an injection of a noxious substance or even a saline substance into the disc, and then say, where do you feel this? Where is the pain? And so 2-3 is up in the head, 3-4 in the upper part of the neck, 4-5 in the mid to lower part of the neck towards the shoulder, 5-6 lower part of the neck and a big part of the shoulder and scapula, 6-7 even extending down into the arm. So those are pain distributions you would expect with each of those levels from discogenic pain. Now, what are the typical postures we see in an average American? And it's typically sedentary postures, often in a slouched position. More and more are we shifting away from standing and activity and more towards sedentary posture. What someone had referred to, and you might have all heard the term, sitting is the new smoking. Orange is the new black, sitting is the new smoking. That all the detrimental effects we know of smoking are starting to show up in people who lead sedentary lives. And that just shifting from a chair to a standing desk has actually helped improve health markers in people. So sitting at the table, going into that slouched posture, very often accompanied by a forward head carriage, which now flexes the lower part of the cervical spine and hyperextends the upper part of the cervical spine, engaging all manner of muscle activity that we really don't need or want. So what are the historical factors in a patient that would lead you to believe this might be a derangement syndrome? And these are not an all-inclusive, but a partially inclusive list. If they have a sedentary lifestyle, often at a computer, if the pain is worse first thing in the morning, gets a little better as they move around, and then gets much worse the more active they are. Why would you suspect that? What do we know about discs and recumbency at night? Yeah, it's the hydration. The imbibition occurs when you're not in a gravity-bearing load. So that's when the discs imbibe fluid, and they're probably, I always, as I mentioned before, I always get my height checked first thing in the morning. That's when I'm tallest. My discs are at their biggest they're ever going to be. In that pattern, now this is an interesting thing. Any McKenzie diplomates in here? Anybody certified McKenzie diplomate? No? It's a curious thing for me, and read this, but I don't necessarily buy it, and I'll tell you why. This idea, this pattern that they see where it's worse in the morning, and then because of the imbibition, and then it gets better actually as you move a little bit, and it feels a little better, but then the more you move it actually gets worse. They argue that that's a derangement pattern, not without inflammation, that there isn't an inflammatory component here. And this would, and argue against using an NSAID for this, maybe just a pain and analgesic, not necessarily an anti-inflammatory. So Tylenol presumably would work just as well as ibuprofen in this case. I don't necessarily buy that, and there's a little bit of basic science to support that. Nuclear material seems to trigger an autoimmune inflammatory response. So if nuclear material moves out of where it's normally contained, the nucleus pulposus, it actually triggers an inflammatory response. A lot of the problem associated with nerve roots, associated with discs, is actually more inflammation than it is mechanical. So I don't necessarily buy, and when you get a new annular tear, at least from face validity, it would suggest that there might be a little inflammatory. So I was curious to hear the reasoning of a McKenzie diplomate on that point. Nevertheless, we'll go on. It's more of a question of academia than it is clinical. As long as you understand that pattern, that's what's really important. It's worse with sitting, often just because we go into a protracted position, the forward head carriage. When we're sitting, it can be a little better with walking and standing, again, only typically by virtue of the fact when you stand up, you bring your head more into a neutral head carriage. So you disengage a lot of the activities that occur with slouching. More common in people less than 55 because of the nature of discs, and they're more hydrated when you're younger, so you would expect more that you would see these kinds of changes. These are the people who often say multiple episodes. This happens to me every few months. It happens 2 or 3 times a year. And then, boom, they get the one really bad episode where they can't self-manage, it won't go away, and they come and see you. And often starts with central pain, and in a certain percentage of these patients, and I don't know what that percentage is, it can even peripheralize. The symptoms will start to migrate out peripherally. In the cervical spine, that would be down the arm and hand. So let's talk a little bit about testing now to identify what can we do from an examination vantage point to help us define this patient as a derangement kind of a patient. We'll talk about this particular way of evaluating. This isn't how you would start with someone, but you can go to that. And this is the sequence that they typically recommend. It's mostly you start out with just sagittal plane testing, and it's by virtue of the fact that the majority of derangement, this is just on McKenzie's observation and many practitioners doing the same thing, finding this consistently, and that is the majority of patients who show up with derangement are made worse by protraction and relieved a bit by retraction. So protraction is jutting the head forward with the chin forward. Retraction is the head more neutral above the shoulders and pelvis, but actually pulling the chin back in. Not tipping the head back, but staying in that same coronal plane and pulling back. So the sequence is, you first do gross cervical range of motion, flexion, extension, rotation left, rotation right, lateral bending left, lateral bending right, and then you first do what you suspect will be a provocative maneuver, something that's going to make it worse. So you actually have them do protraction and see if it makes it worse. Your hope is that it will, meaning now you're going to be more confident that this is the pattern you're identifying. Then you do retraction on a repeated. They say sometimes you can do it sustained. More commonly, the way I always was taught was just do it on a repeated basis. Do a series of repeated retractions and then monitor the response. You're hoping that this is going to be a direction of benefit. Then you do retraction and extend from the retracted position. And just keep doing it. And if it doesn't give you any response, you can't really make sense of it, but you're still thinking, based on history at least, this is derangement, these are all patient-generated movements. You can shift to provider-generated movements if these don't give you the response you're expecting. So in this case, you go back to that picture, you put the patient supine, you do, you do axial traction first, and then put them into a position of retraction. And if that doesn't do it, then axial traction, put them into retraction, and repeatedly put them into, or in a sustained basis, put them into extension. And see again if you start to see some of the response to that. Ideally, again, you'd hope that's the direction of benefit, where you're going to see one of or more of three things, right? Reduced pain, improved mobility, it gets easier, and potentially centralization phenomena, which we'll mention in a second. If no change from the sagittal plane movements, you can start to go in different planes. In this case, you then now test them end range loading and rotation. So you have them go into full rotation, either direction, and then test them. And that typically, because most rotation occurs where? Upper cervical. So you're really looking at the upper cervical spine. Then you could test them at end range loading and lateral bending, which is really more of a mid to lower cervical phenomenon. But first start out, as I mentioned, in the sagittal plane. Now, how do you make sense of what you're finding with doing those repeated movements? By definition, according to their protocol, it should not be painful during the arc of movement in the direction of benefit. So if you're going into retraction with extension, they might say, oh, it hurts at the end, or they might say, yeah, it just won't go any further. But it doesn't hurt during the arc of movement. If it does, then it's probably not a direction of benefit. So if they do protraction and it hurts right throughout the movement, that's a direction of provocation. You want to see that it doesn't hurt during the arc of movement. Again, as I mentioned, it's this pattern you're looking for, and it can even occur in the upper cervicals. Direction of benefit should reduce the pain, improve mobility, and or centralize the symptoms. And centralization is whereby distal symptoms progress more centrally. So it might be that the pain changes from mostly in their hand now to mostly in their upper arm. Or it might be mostly in the arm and now it's more in the neck. And sometimes with centralization, it doesn't always occur, but if it does, sometimes the central symptoms get a little bit worse. As long as the distal symptoms are abating, it's an okay thing. So again, it's doing these repeated movements, the end range loading movements, and looking for the response. And hopefully you find a direction that benefits the patient to reduce pain, improve mobility, and centralize. Or perhaps just one of those, initially anyway. Now, let's talk about evidence that supports this approach and why consider utilizing McKenzie criteria. Well, there's some research evidence that really is supportive of utilizing it. These are broad categories that McKenzie talks about: derangement category, dysfunction, and postural category. And patients with neck pain could be reliably classified according to Clare's study back in 2005. There is no real gold standard here, right, for classifying according to McKenzie protocol. So you have to, they did originally start doing some studies where you looked for concordant pain with discography, and that proved to you that the pain was discogenic. That still doesn't 100% support the idea of these patterns of derangement. The criteria we talked about already with history. With examination, you're getting all these responses to end range loading, finding a direction of benefit. There might be an intelgia with these patients too, that they might be in a more torticollis position, they might be in a more kyphotic kind of a position when they present. They very commonly have limited range of motion, even in protraction and retraction. And hopefully you'll look for these centralization phenomena. So enough. That gives you at least an appreciation and an understanding for how McKenzie classifies. Using McKenzie protocol, you can classify the patient as having a derangement. And again, to be used to guide your treatment approach. Now, we've already talked about this drawing. We'll talk about joint dysfunction as another broad category of pathology. And in this case, here you have nociceptive afferents coming into the dorsal horn of the cord, and some of them stimulate these interneurons, a second-order neuron, which goes up the anterolateral spinal thalamic tract to the thalamus, carrying pain. And it's a stimulatory response here. In addition, we have interneurons which try to impede that second-order neuron going up to the thalamus and you see there's two little negative marks here. This little neuron is an inhibitory neuron. So it wants to prevent that pain information from getting up. That neuron is stimulated by a mechanoreceptor. So this principle of the gating mechanism of pain control is this, where large myelinated mechanoreceptive fibers have an inhibitory effect on nociceptive fibers coming in from the same level. So you bang your elbow and you rub it. You stimulate the large mechanoreceptive fibers and inhibit pain. So what are some of the historical features which would suggest to us that a joint dysfunction is actually occurring? Not totally clear on reliability and validity of these measures, but I'm going to mention them anyway because it seems to be the best we have. So if the pain's more local into the neck, if it's more on one side than the other, we tend to think more of facet. If it's accompanied by a headache, very common to have cervicogenic headaches from facet pain. Pain with rotation and extension of the neck. So if you extend and rotate and it makes the symptoms a little worse, that seems to be common. So when patients say, if I try to go look over that way, it hurts too much. There can be trauma, but remember it could be insidious. It could be a repetitive motion injury kind of a situation. The first worst facet problem I ever had was when I went out and tried to use one of those pole saws and cut a bunch of branches in my yard and then couldn't move my neck. No systematic reviews which really have identified the accuracy of using these criteria, but it seems to be about the best we have in terms of defining this and trying to differentiate it from a derangement kind of a patient. And this is that same type of a drawing where they've gone in and inject saline into the facet joints and then looked at what's the distribution of their pain. And so you can see C2-3 is this big bundle here. C3-4 is this big patch here. The dark area is just where the two overlap. C4-5 is this big patch here. C5-6 is this big patch here. C6-7, this big patch here, which was pretty similar to the disc, just not as extensive. The disc tended to give a broader distribution. And that kind of makes sense when you think back to embryology and the derivation of these tissues from a somite. So that a somite has a nerve coming into it, and then that somite is going to differentiate into a dermatomal portion, into a myotomal portion, and into a sclerotogenous portion. And it's that sclerotogenous portion that's going to account for these kinds of tissues. And so it kind of makes sense that the sclerotome, some of it will be the disc, some of it will be the bone, and that you would see similar patterns here. Now, is there any validity to using segmental joint palpation as a criteria for defining facet as a problem? And segmental joint palpation is where you use kind of the end of your thumb, say, or finger, that right at the end part, move as much of the muscle away as possible and just see if the tissues over that joint area in question are really tender. It's nothing more than that, just assessing for, is it tender? And you always use your control, which is the uninvolved side, or levels above or below. And it should be, really much more tender at that level than either the other side or the levels above or below. No one has ever, I don't think, replicated Gwendolyn Jull's results. I mean, 100% sensitivity and specificity is almost unbelievable. When something's too good to be true, it might be too good to be true. Now, this segmental joint palpation of the cervical spine, when they looked at reliability, actually the kappa, you remember, is looking at how much the results match when you remove chance as a variable. So if you're going to flip coin, you got a 50-50 chance of getting a particular result just because of chance. So you have to remove that when you start to look at whether results actually correlate with one another. And in this case, it actually shows very good reliability in headache patients from 2 to 6 examiners. That is, they could agree that, yes, that area was the tender area. Segmental palpation for comparing patients who have neck pain versus control patients. And predictive values, negative and positive predictive values, are somewhat akin to likelihood ratios. Let's just more focus on sensitivity and specificity. Those are actually quite good numbers to use it as a differentiating criteria to help you identify what the painful segment is and to identify patients who are having pain versus patients who are not. And a further elaboration of that study, they had 22 people with neck pain for at least a year and 53 controls who didn't have pain. I don't know, I typed that twice. Pain provocation with segmental palpation gave the best results to try to differentiate the two. And they used other things like range of motion, flexion, extension, and rotation, was not able to differentiate who was a neck pain patient and who was not. And they also looked at foraminal compression and test and upper limb tension test, which did provoke neck pain in the neck pain patients, but it could be used if you're looking at it just to show neck pain, but it didn't cause any radiating symptoms as you would expect that test might, because these were just local neck pain patients. Segmental palpation and its validity, palpation was the most sensitive clinical sign of Z joint involvement in chronic headache post-motor vehicle accident patients. So this idea of using palpation as a tool to identify the painful segment, it seems to be quite useful. High sensitivity, not very specific to identifying neck pain patients though. So it'll catch them all, but it doesn't always tell you what the cause of that problem is. Another study, a much higher incidence of symptomatic joint dysfunction in patients who had cervicogenic headaches versus tissue tension headaches or migraine headaches. So in terms of trying to differentiate a patient with a headache into either cervicogenic or tissue tension migraine, you just use this test to palpate for the tenderness over the apophyseal joint. In this study, what they did is they did facet injections at multiple levels and showed that it showed consistent pain patterns, just like that drawing I showed you. If you inject a noxious substance, hypertonic saline, into the facet joint at C2, you'll get that very characteristic distribution of pain. And then April, it was an interventional pain management or radiologist. They did facet blocks. If you inject an anesthetic into the facet, it's got to relieve the pain that the patient presented with. And then they even did Bogduck did a study, 56 patients with post-traumatic neck pain. They did both discography and facet joint blocks. 40% of the patient had pain with both, that there was concordant pain with the discography and relief of pain with the facet block. 20% only showed up as facet pain patients, and about 20% showed up as disc only. So maybe it isn't that we're seeing disc versus facet separately, but they very well may be concurrent. So you can't just rely on one test. That's why it's so important to do this in somewhat of a structured format, so that you're not just picking tests haphazardly, but you're following through in a fairly consistent way. So just jumping back to that idea of now, what's the pattern that we're seeing here to help us identify this as a facet patient? Local pain, rarely into the upper extremity, usually unilateral, very often with a headache, made worse by rotation and extension, history of trauma, and then we're going to find now a couple of fairly consistent examination findings. These patients very commonly will be positive on the extension rotation test. You extend the neck and rotate and find that it reproduces the pain that they're having. This is much more common when the problem is in the lower cervical region. Segmental, it'll just show up a little bit more than when it's in the upper cervical. Palpation for segmental